Well, a great morning again, and the state has traditionally been the primary sector, rather actor in health governance, providing political leadership, priorities setting and initiating and implementing health interventions. However, from a health financing perspective, there is need and a downward spiral in the government's budgetary allocation to the health sector, and with the sector's budgetary allocation often oscillating between 6% to 9% of the total national budget for the last 5 years. Now, resultantly, this chronic underfinancing has set the stage for the health system characterized by inadequate health facilities, constant drug stockouts, inadequate staff, and poor remuneration of health workers, to mention but a few. Now, the impact of COVID-19 necessitates a more critical reflection on the role of government in health service delivery and what is to be done to build a resilient public health sector, which is the first point of the call for most vulnerable. Joining us for this conversation, we'll be having Ms. Alana Kembabazi, a Right to Health Program Manager and the Initiative for Social and Economic Rights. And then we have Ms. Ruth Sachindi, the Director Monitoring and Inspection at the Uganda Human Rights Commission. And we'll have Ms. Zamina Malole, a member of the Equal Opportunities Commission. Good morning, ladies. Good morning. Now, to start with, let me start with Ms. Ruth Sachindi. So far, have the measures of COVID-19, the way you've seen from the government of Uganda, have they, the way they have been undertaken to contain the pandemic alive, are they a realization of the real health we need as a nation?
Well, the measures that have been put in place are critical in avoiding the spread of COVID-19, whether it is transport. When you look at issues or the sensitization that has been taking place, calling for people to wash their hands, sanitize their hands, the law on requiring everyone to wear a mask in every public space, issues of when they have sent out communications with regard to who to call, putting in place national and district COVID task forces. All these measures are critical and very important. And there's been a sense of preparedness within the health sector where they have, well, they looked at how many ventilators we have in the country. For example, Mulago, we have 50. But this is not sufficient. It is good, very good, because we know that students are out of school. We are trying to protect them as much as we can. And because of these measures, there was a delay in the spread of COVID-19. However, if we're going to look at an optimal address of limiting the spread of the pandemic, it has to be holistic. The population itself has to play a critical role in the prevention of the spread. Now, what the President did and what the Ministry of Health did was very commendable. In fact, around the world, we are commended for our initiatives and our measures. Now, the role of the population, when we talk about protecting and promoting human rights, human beings, we as the rights holders, also we have a duty and responsibility. So we have duties and responsibilities. Now, when there was a laxity, the relaxing on the lockdown, that is where we have seen things go haywire. This is where people forgot about the masks. They forgot about washing hands. And when you go to downtown, you'll be shocked at what's happening. Everyone trusts the other. Now, last week I was somewhere deep in Ruchiga, Kabale, and Isinjiro, and we are monitoring the preparedness of the population. Now, it is not only in Kampala, it is in every city and town in Uganda, where people have relaxed, they have forgotten their responsibilities, and because of that, it is not surprising that we are seeing more infections within the communities. Now, when we talked about some of the respondents, one gentleman I found in Isinjiro told me, "You are all covered up, but for us, we can't do this in our community."
We are Africans.
No, we trust each other. It is you who are coming from Kampala who are all covered up, and we have seen you sanitizing every 30 minutes. It's you that we fear. But we know each other and we trust each other. We are relatives. We've married within the community. We trust each other. In any case, if you use a mask, then it means you are proud or you are saying that I have something, I can infect you with something. So the others, the community members, are shunning away from the masks because it is being perceived as something of pride. Now the question then is, how do we ensure that we change, or the communication, the way we tell the information we tell our communities, how do we ensure that they change the attitudes? Now, we ask them whether they know about wearing masks and they need to wash hands. They said, we know all that. In fact, we have government masks. But no one in the community was using any of these masks. And now we have seen that around the country. Now, government will put in place mechanisms, but the populace, the public, plays a critical role in ensuring that there's a limit in the spread of COVID-19. Now, when we are dealing with COVID-19, we have to look at the health structure, the infrastructure itself that we have had as a country. We as a country have been struggling with health as an issue. The infrastructure, the personnel, the payment of health workers, it has not been sufficient. And now we are bringing in COVID-19. We did not anticipate it. So we have a fragile health system. And COVID-19 has exposed the levels of fragility of the health systems around the world. Even for the countries that we thought were powerful and they had the best health care. In Europe, in America, you have seen the deaths. In South Africa, I have friends there. We are told that the nurses are sick. Now, we have to protect our health care personnel. The nurses are sick, the ambulance guys have run away, or they are sick. The hospitals, people get into hospital, and I'm talking about public hospitals. They have no one to take care of them. Now, I am thinking, if this comes to Uganda, yes, we prepared Nambole. Is it sufficient? Do we know the doctors? Do we have the sufficient personnel to be there? So, yes, we put in place good measures at the initial stage, but now this thing is going to touch to the core of the health system that we have, that has existed. And that is why I'm saying the initial preparedness was good, but now we are dealing with the real issue that goes to the core of our health care system, infrastructure, at the health system, are the health workers available? Are the health services accessible? Are the tools of trade in place? Ventilators, if Mulago has 50, is it sufficient to cater for 40 million Ugandans? If we are looking at X-ray machines, do we have them? If we are looking at the tools of trade within hospitals, are we ready? If we are seeing South Africa ran out of protective gear and they started wearing raincoats, are we prepared? Now, we have gone to some of the health facilities, and I was shocked. Health Center 4, the doctor was saying, well, they will bring them, but when we shall refer them. I asked him, how many ambulances do you have? He said, we have 2, but 1 is broken down. So I'm thinking, and he's near a refugee settlement. They're the ones that are serving this. I'm thinking, so if we have 1 referral, one ambulance, and they are not sure, I asked them, do you even have a... He said, yes, we have a quarantine center that we can take them to. I said, I'm talking about a hospital. Do you have sufficient beds? He said, we don't have this. I said, have you been trained about how to treat COVID-19 patients? He says, well, I know the basics, but the details the ministry has not yet provided for
Now, that's
us.
the resourceful
Now,
person
that
on
is
ground.
the reality on the ground.
Wow.
So we are saying we need more that can be done with regard to the health system and not just the preparedness, because we have moved away from preparedness.
Thank you so much, Ruth. Going straight to you, I mean, from the equity perspective, she's really taken us on the ground, and I'm really excited about that because I'm so much rooting for Montuwawansi. But now, can you comment on the adequacy of the COVID-19 response in the health sector? Was it adequate enough in terms of the equity perspective?
Yeah, thank you very much. Once again, I'm Malole Zamin. I'm a member of the Equal Opportunities Commission. At the level of adequacy where the health sector stands now, I would say that it is not that adequate, 100%, but at least there is some work that has been done. Because if you look at the approach which the health sector has engaged, is more preventive than curative. And I think the preventive measures that have been put in place so far have really walked us a journey under the circumstances, because you realize that if the health sector, that is government, had not hardened on some of these preventive measures, given the stand of Uganda today, I don't know where we would be. Because we have had our neighbors day in, day out. They started witnessing loss of lives, I think, 4 months ago, because we are at 5 months, ever since we were attacked by this unfortunate situation of the pandemic. But also, I want to say that we need to do more, because we cannot just hang into there by looking at the preventive measures, but we also have to go on to another level. Because when you look at the kind of preventive measures so far that have been put in place, of course there has been some questions as far as equity is concerned, because the most vulnerable, all people have been affected, but the most vulnerable have been affected most. They have really felt the pinch. And you may find that at least at the same time, they are always at the periphery of receiving some of these preventive measures. Because even at the onset, when they were trying to give out some essentials like food, when they were giving out some essential protective gear, you'd find that we had to move in to say that we need to use an equity lens when we are giving out some of these. Because you could also, through media and also through calling us at the Equal Opportunities Commission, we could really feel the outcry. They would be the ones to say we haven't received food. They would be the ones to come out to say they have jumped our houses.
Or
we
they
have
received
heard about
food and
this,
it was bad.
and maybe we have received food, but it's not good. So we had to rein in the task force at the national and the local government level to tell them that, hey, listen, when you're looking at some of these issues, you also have to consider these people who are always having these issues bite them the more. Because, again, when we look at the budget, if I can jump in there, because we are also assessing the health sector for gender and equity responsiveness, we could see that the budget process was already ongoing, and some of the sectors had already budgeted by the time the pandemic hit us, and they were in the process of submitting. So we had already got some of the budgets for the various sectors to be assessed. But this time with COVID, we put a lot of our interest in what are some of these measures, because if COVID is here, we have to also see how we have to live with it, because it is here, yes, it is to go, but we have to look at circumstances in which it has to be sustainable, and we have to live with it. So in the future, that is during COVID and beyond, what is it that the health sector has in order for us to be secure, in order for the vulnerable people not to continuously be affected? So we looked at the budget and we said, what is the budget of the sector and what specifically is being put towards some of these? Because we said, along with the curative or with the preventive, we want the curative medical supplies. And we looked at their budget and we saw that it was something like 7.7 billion, which was being put to that. And we also looked at issues like health insurance. What is it? Because much as the health insurance bill is in the offing, but we also wanted to see those ones who are already like accessing, because these are times like what Ruth has just said, where we have been unveiled as far as the health sector is concerned globally. Because you can see that a lot of things are happening and nobody was ready for this to happen. But now this is a lesson. So we wanted to look at this sustainability, because it is only through insurance that people can be secure. And on that, we have also made a recommendation to fast track the health insurance bill because it is more needed than it has ever been.
Maybe if I can allude to what Ruth earlier said, that when she was on ground, she tapped into the experience of the health workers on ground. Did you, as the the Equal Opportunities Commission, try to reach out? What kind of training are being given to the Rural Health Center 3 nurses and doctors vis-a-vis the ones in Kampala or in the suburbs of Kampala? Because what she's saying to me, it's alien. Because when you go to the hospitals here in Kampala, you can tell that there is a higher lateness of the disease. The doctors, the way they respond to you. But the health workers she interacted with said, I know the basics. So did Equal Opportunity go that far that this training can cut across, regardless of your region where you are or the health center where you are?
Yes, we made recommendations to the National Task Force as well as the Ministry of Health because we even had to, first of all, raise some correspondences in which we categorically mentioned the importance of information sharing because we said that this information should be universal and inclusive where it has to be in accessible formats and it has to reach each and every Ugandan. And when we are also having meetings and interactions with the local government, the task force that have been put at the local government, because we have had several, we also made it emphatic that it is important because this complacency is coming out of maybe lack of awareness and people taking situations for granted. It has to be continuous because as people are moving out, as the lockdown is being lifted, I think there has also been some people pulling out. In terms, there has been some sluggishness that we have witnessed in this continuous campaign on the COVID. So I would think that this is the time at which we would intensify the campaign because we have even started witnessing some
more community cases,
community cases and even deaths at that. Because I remember in the remarks of His Excellency, he was saying he was shocked at the Ugandans saying that they would want to see at least some people dying. How come here people are not dying? So that shows you that there is a high level of ignorance, but it does not only pertain to the people, the wananchi, but also the service the service provider, the people who are in service. Because I think this has to go back also to the ministry on the packaging. You know, how do you ensure that every other day the people are taken through drills to enable them recall, remember, and also practice? Because if the people come to the health center and they find that the medical personnel are present, but they don't have any protective gear, they don't have, because I think those were the issues at the beginning. But today, government has done its part and has tried to ensure that in each and every center, they try to send the protective gear because the worry was about running out of some of these equipment. But I think they have even also gone beyond to also ensure that the people get the masks. But when the people come to the mask, but when I came here, what I was first asked at the gate, do you have a mask? I said, yes, I have it because I was in a car. I said, because I have a lot of AC around, I'm going to put on my mask as soon as I can't get out without a mask. Then they asked me, have you sanitized? I had to sanitize. But you find that some of these measures, Ruth, I think you also witnessed, are not there. I don't know why these are not there because a lot has been done, but I think we just need to continue singing the song, if I can call it a song, for us not to relent.
I think
the issue
is about the complacence of the populace, that and all that kind of thing. But it's something we need to change. Thank you so much. I'll get back to you, Madole, later. Miss Alana Kembabazi, world over, the readiness of public health systems to respond to the pandemic has been central at every discussion. Last night we had a discussion at UN and it was still about the pandemic. From your perspective, what was the status of the health system in Uganda before COVID-19? And do you think our health system was fairly ready to respond to the pandemic the way we responded?
Thank you, Andrew.
I studied the word fairly ready.
Fairly ready. Because I tend to come here and bash Kevin. No.
Oh, yeah.
I think that just like Ruth and Zamina have talked about, this sort of exposes gaps because we're dealing with a pandemic which can be mitigated. People can wash hands and use masks, but you can imagine if it was like just a different kind of pandemic. We've seen Ebola, just a different one where you should really, which either way, Ugandans I think deserve resilient health systems. And for me, there's a strong focus there on public because we have to think about the most vulnerable and how easy it is for them to get health care. And within the design of our system, the public health system is supposed to do that. We're supposed to have a health facility within 5 kilometers at least, such that if there was a lockdown, you would not have mothers dying because they can't walk to the facility. But what happens in practice? A couple of quick figures. For example, we have 29 constituencies that should have health centers for, but don't have one. We have 39 districts without district hospitals. We have 331 sub-counties lacking health center 3s. 132 sub-counties lack health centers completely, right? So you can already see that this, first of all, contravenes government policy, shows how unprepared we are. On ambulances, we have a department within the Ministry of Health on emergency services on ambulances. We have, they've even actually costed what it would mean for us to have a proper, great ambulance system where the person can be stabilized along the way, not just rushing you to hospital. Not this business of the president saying, everyone bring your cars, now put them at the district. That's not an ambulance service. Even that we failed. We waited till the pandemic. Guys who can help with a car, and then we sent. And we actually have a budget for this. It will take about 447.1 billion.
So, can let
me just finish an ambulance, make it clear. It will take about 11 million US dollars or so to have this sophisticated ambulance system all over.
Yes.
But we don't. And yet we spend money. For instance, we have a project on Luvoa that is going to cost $371.7 million. The World Bank funded a $17.7 million US dollar project to help poor mothers, of which there were huge leakages. The poor mothers didn't get it. Yet we need just 11, billion US dollars have an ambulance service that is everywhere. So I think there is a real question here about our priorities as a nation, and whether we are really thinking about how to safeguard health for the most vulnerable. We've always known you can escape our systems, go to India or whatever if you're a leader. And these are budgeting issues. Like she said, the Equal Opportunities looks at them every single time. It does a gender and equity budget assessment. It's still not done. Even as the pandemic was coming up, they made a budget. Now recently I had the minister going back, supplementary budget for blood. You mean you did not know that we have people, so that's what I'm saying to you,
measures.
That we have to look at these things where instead of this piecemeal project saying I'll only do over poor mothers here in Bujiri, over here, you should look holistically and say where are the gaps. Where do you start? If you have limited funds, I believe you always start with the most vulnerable. They're the ones that are least able to really take care of themselves. And so you have to think, okay, at minimum, let us have a strong public health system, because the most vulnerable go there. The private, you're not going to have people going deep into Rabachi, Hama, setting up facilities, or there in Kapetawo, in Amdat, because it won't be profitable. So the government really has to make sure, at minimum, we have a strong public health system, and we haven't had that. And I'm actually worried because at the beginning, I remember you and I talked, and we talked about this was an opportunity for us to rethink priorities. So I actually thought in the budget process I would see this energy.
Coming through.
I thought this is a moment of fundamental change, of reckoning. But I'm very worried because I don't see that.
Going back to my question, Alana, do you believe or do you think our system, our healthcare system, was fairly ready for the pandemic?
No. I think in some ways, to be fair, there was an alertness that we had. At least we're not like America denying whether there is COVID. We've been through Ebola and all of that, and so we were alert in those instances. But we should have been more prepared by at least having the basics. Like I said, if we had health facilities, if we had health workers with protective gear. During lockdown, for example, health workers, one of them was not turning up. So ISER has these community advocates. And they say the health worker is not turning up. And we said, engage with the health worker. And the health worker said, I'm not turning up because I don't have anything to protect myself. I'm also scared. I don't even have soap and water at the facility. And so, the basics. This was before they told us about masks, right? And the person was like, I'll take my chances and I'll be absent. We shall see what you guys will do. So we have to, think through that and say, okay, we can say we did not expect corona. No country did, like Ruth has said. Even the developed nations are struggling with this. But our gaps in the health facilities, we knew. We knew drugs were running out. We knew that health workers lacked protective gear. They were going on strike. And even now, they are still shouting about the same things. So we cannot keep shielding ourselves. And I think we need to move this discussion even beyond COVID-19. Because, you know, COVID-19 is one thing. It has shown us how easily failure to pay attention to healthcare can completely cripple your system. And failure to pay attention to healthcare for the most vulnerable.
The vulnerable.
Because we like to say every single time, for example, they will say access. We've increased access. We've reached this many women. We've done this. But have you reached the poorest? Have you reached the most vulnerable?
Are you trying to allude that we have a gap in research with regards to how we plan for the nation health-wise?
I think
because if there was adequate research, then it would inform the planners of this country and the planners of the ministry as well with regards to this.
I think it's beyond research. It's just a political commitment on both ends, whether it's government or donors. We need to stop patting ourselves on the back to show quick impact. We've reached this many people. Because if you look at the Uganda Bureau of Statistics, it will tell you where the poorest are and the most vulnerable. It often tells you, for example, the poorest region, the one that's left behind always is the north. Then you go east, you know. It will begin to tell you, and among persons with disabilities, and we've been engaging with them, and I think there's a whole gap there around sort of differentiating the different disabilities. But it's able to tell you, because you can get this data. So you have the Bureau of Statistics doing one thing on its own. Then you have the way things play out. Then we have our plans and policies that seem nice on paper, right?
But
like we are going to reach all these people. And I think we need to stop this business of using the poor as a sexy catchphrase. Adona comes, we are reaching poor people. And now you're doing medical credit fund, it will reach the poor people.
Absolutely.
We need to get into the questions and say, are you doing so? And part of that is following the money.
Okay. Well,
like
thank
the
you.
budget, like she said.
Thank you, Alana. Well, it's a conversation we're still having. It's entirely about how we're building our nation back, especially with public health. We'll take a break, but keep part of the conversation on our digital platforms, that is NTV Uganda on Twitter and on Facebook. Let us know where exactly. Well, it's still NTV, and we're looking at the resilient flow and how we're building our public health. With me, I have Alana Kembabazi from Right to Health Program Manager. That is Initiative for Social and Economic Rights. And I have Miss Ruth Sechindi, the Director, Monitoring and Inspection at the Uganda Human Rights Commission, and Ms. Zamina Malole, a member of the Equal Opportunities Commission. Well, going back to you, Ruth Sechindi, is the Uganda Human Rights Commission adequately monitoring the COVID situation to ensure that government does not forget its primary duty of ensuring the right to health is respected, protected and fulfilled?
Yes, the Uganda Human Rights Commission is monitoring the COVID situation, not only the right to health. And we have been monitoring education and the impact of COVID-19 on education, looking at the schools, the students or the learners, and then the material that was sent to the learners, how effectively is it being used? We went out to communities to see how students are using this material. Did they receive it? And we have written an advisory to the Ministry of Education just to guide on that. Then we have looked at the electoral process and how COVID-19 is impacting on the electoral process. Looking at you have seen people coming together and I don't know, I don't want to call it demonstrations, or let's say processions, and how it's impacting on COVID-19, because that is a threat. And we have written an advisory to the Speaker of Parliament together with the EC. Now, we are currently writing an advisory on the right to health to the ministry, bringing out all these issues that we are stating. But we are also on the ground monitoring, and we are in touch with the district COVID-19 district task forces as well as the national task force. But then when we are looking at all these things, particularly the right to health, we go back to the preparedness and the resilience of our health system. How effective is it in view of our previously fragile health systems? Are we adequately prepared? Now, I do not want to downplay in any way the mechanisms that have been put in place. Alana has talked about the ambulances, the cars. Well, that's what we can afford as a country. And I'm glad we are doing this, because we couldn't have sat back and said, okay, we don't have a car, we can't ask the populace to
it looks
contribute.
like a knee-jerk
I am
reaction.
happy with that. But in addition to what has been done, we want government to do more.
Okay.
To sensitize the public on what has to be done. If we need to save lives and have minimum lockdowns here and there, for example, Chikumu and all this, let us do that to save lives, because you can never have another life back. And these things spreads like wildfire. We cannot afford to be complacent. We cannot afford to take things for granted. Now, we also have to take into consideration the information that we send out there. Last time we saw Bad Black, we have seen this young boy for the student, and I think that was commendable. You realize that the Ministry of Health tried to reach different groups, and I think that was commendable. Cultural leaders, let's use someone who is appealing to cultural leaders. For the sex workers, let's use someone who is the sex workers look out to. For the young little kids, let's use, what's his name?
Fresh Kid.
A fresh kid that appeals to the kids. That was commendable. And then things happened. We started seeing videos of patients dancing.
Yeah.
Now that
people having house parties.
Yes, people having house parties, going to club. That was the undoing of the message. Now the government has to track this. Social media is alive. And people really look at it. So the information started saying, oh, we don't have COVID-19. Have you seen the people they are calling patients? They are dancing. But it doesn't mean that everyone who has COVID-19 is on their deathbed. It means that there are people who have it, who move with it. So be safe. Now, the ministry had to come out and do a rebuttal to that video and explain that not everyone who is sick, but that didn't happen. And people, it became deep-rooted in people's brains. And that started undoing everything, every good thing that had been sent out there. We need to have more languages and not use only English. So that our information, we use the human rights-based approach. It is inclusive and everyone participates. It has to be holistic and it has to be interlinked, because human rights are interdependent. So the right to health has to feed within education. The media has to play a role. Freedom of expression has to be there. We have to look at issues of not only availability, accessibility, how accessible are the health facilities, how acceptable are they? Now, there are communities that are also have religions that do not go to hospital. We should come out and explain to them and see how we can change their attitudes. We need to sensitize and do more sensitization right now. However, we need to prepare as a country. We need to prepare our health systems. Yes, initially we talked about the 50 ventilators in Mulago. How many ventilators do we have in all the other facilities, in the referral hospitals that we have? How many health ventilators do we have in Health Center 4? Now, the public has to be informed about these things. The numbers that were sent out, the toll-free line that we are supposed to call for the COVID-19 task force, how many people still remember that? They have since forgotten. They have since forgotten. Now, our television, the media also needs to play a critical role. Responsible reporting. Now, they have moved away from there, and then we have gone into elections. We have forgotten COVID-19.
We have shifted gears.
We have shifted our focus. Like it is non-existence, it's not important. Every day we used to listen to the numbers of the new infections, what has happened, any new development. We have moved away. And all attention now is on election. I think we need to refocus. We need to rethink our strategies. We need to prepare as a country. That way we need to save lives.
I agree. Well, thank you so much, Ruth. Coming back to you, Alana, from a health perspective, would you say government's response has been commendable, and has the health sector been funded adequately to meet this need, even post-COVID or post-lockdown?
Like I said, funding is most of the gaps with the health sector are tied to funding. There's some that are tied to still stewardship, and I think that's a different conversation. But funding has been a critical shortfall. We've seen a sector that has never really gone above 9% of the national budget, so it's been 69%. Even now with COVID, and you have to be very careful. Doing budget advocacy and analysis like we do during this time has been difficult, because You look at the ministerial policy statements, you think you're finished there. Supplementary budgets. The problem with supplementary budgets is there's very little oversight. They are not sustainable. You're not able to say, okay, this is where I am targeting. We've consistently seen a number of unfunded priorities. Ambulances and emergency services have been one of the ones that have just been shelved. And as you've seen, that's why we had this very knee-jerk reaction. You know, sort of other issues too around like having sufficient health workers from a financing perspective has been really problematic. We've also seen other issues pertaining to vulnerable groups, you know, for example, you know, simple things like whether we don't have any sign language interpreters in health facilities. So you're wondering how they're able to interface with the health workers. How am I able to tell you I have cough, flu, fever? You're just ignoring a whole group of people. But at the same time, we see a lot of donors coming in, and there's this perception that the health sector is properly funded because donors come in. The challenge is where the money goes, if it goes to piecemeal projects. ISER last week, for example, launched research on a World Bank funded $17.5 million US project that was supposed to be sort of supplementing these gaps and reaching poor women. Except 68%, according to the Office of the Auditor General, of the women who are reached were not the poorest. There was a real leakage there, right? So sometimes when you go as donors and support projects that do this one little thing or this one little thing, it's better to just put the pool of money and look and say where are the unfunded priorities. Like I said, having something for me as shocking as a lack of a proper ambulance referral system and for it to constantly be an unfunded priority is very concerning for us, right? So I think from a financing perspective, we have to think about that. The other thing Zavida did allude to was around national health insurance, which is to say, first of all, there's a consensus that there should be, government needs to put money into the health sector, and it comes from our taxes and from other sources, but it should put money. Number two, if you're going to sort of reduce out-of-pocket costs, do it through national health insurance, but make sure that in any national health insurance scheme, the vulnerable, the poorest are covered, and government must put in money. Right now, there was a discussion around it, which kind of stalled when the president, I think, got involved. But it still wasn't clear to us, is government going to put in money to make sure the most vulnerable
but you see,
are going to be
It's only 9 million Ugandans who pay tax, and the rest of the population depends on the 9 million. So how do we arrive to that?
I think that there are a couple of things. I think the fact that it's 9 million Ugandans who pay tax is already a shortfall of government. Means they're doing a very poor job in
collecting
that
taxes.
But not just that, in curbing illicit financial flows. ISER will be releasing other things later on, but illicit financial flows is an area where you could really get money. And we have a whole system where we have refused to even track the total number of illicit financial flows. Yes, refused, because they track one little thing here, they track this low-level corruption, but they're not tracking the money that escapes the country, really, in taxation. But two, like I say to you, I think we need to stop saying that the health sector would only be funded by these 9 million Ugandans' taxes. Because government gets a lot of loans, it gets a lot of grants. I gave you an example of a project, which, yes, it's came to government, but it's not you don't count it in your pocket. That's the problem, because the project funds this bit. Even think about right now with the COVID situation, how many loans and so forth are we getting? I don't know, social protection, I don't know, health, preparedness, PPPE, but you want to have them in a pot and say, this is the money, now of this revenue, how much of it is going to government? And also, like I said at the beginning, it's also an issue of priorities. We have realized with COVID, and I keep hoping we have, that if you don't fund health, your economy is going to suffer. Everything you are saying is just not going to work. Because before they said, no, we have to put, if you compare the 6 to 9%, whatever, that range that we're getting in health versus the one they give in roads, or, you know, sort of, we're moving to middle security. And that is an unclassified security. There is a classified security.
It's classified.
So when you compare those, you realize again, it's an issue of priorities. And it's now that we are realizing, wait, you know, national health insurance, people who are against it were saying it will make it too expensive for the employers or whatever. Well, now, if we actually all had to pay for our COVID treatment like other countries have done, we would be properly devastated, right? But the third thing is, if you're saying we have less money, let us focus on the thing that will deliver for the poorest, the public health system. Because right now you're saying you have less money, but you're coming up with a proposal for a medical credit fund where you want to put in some money of government that will go to private facilities with no assurance of how they will make sure they deliver healthcare for the poor. There's an issue of priorities. If you have Luvoa and you're saying you're going to do that, you know, or this other project which we released last week, but government put in $3 million US as well in that pocket. Why not get that money and put it in the public health system? At least make sure those who could not take care of themselves are covered. Okay. That's where you would start.
Okay, thank you, Alana. Coming to you, Malole. We've seen enormous resources obtained and allocated over this period. Government saying we have allocated this much money to this, we've given these people this much money. Has the government done enough to protect the right to health of the most vulnerable? Alana is alluding to that when they walk into health centers, they're well taken care of, regardless whether they have money or not.
Thank you very much. Like I said earlier, but also in line with what the discussion, the line in which the discussion is going, whether government has done enough. I think, like I said, that there are some interventions that have been made by government. First of all, to start us up, to start thinking of the people who are vulnerable, at least by putting some policies in place that can enable things happen. And one of them, like I said, now, that strict checking to see whether they are doing enough on the part of those who are vulnerable through the Public Finance Management Act and the attendant sections on assessing for gender and equity. Because when we are assessing for gender and equity, we are looking at how much budget has been put as far as people who are vulnerable, like persons with disabilities, like the vulnerable women and men, boys and girls, the older persons, what is going there. So like in the recent assessments, we looked at that and we saw that government had put some money. She had talked about ambulances, at least.
She loves ambulances. So.
Yeah, let me first go to the ambulances. Because as far as the ambulances are concerned, there is some money that has been put against the ambulances. And I think it was something which I would say is commendable, because given the kind of health system that we have, the ambulances are very, very critical because of the emergencies that are likely to arise. So the National Ambulance Services under the Ministry of Health, they had some money put. That is something like 483 million shillings. Alongside, I think the people of Uganda have also done a commendable job during COVID by donating, because I understand the donations that were in cash and you know, physical donations. There were some cars that were donated for emergencies. So I want to think that in the shortest future, we shall have more ambulances than we have been having. And us and the Human Rights Commission will go back again to assess and see whether these ambulances really reached those ones who should get them.
The president, when he was addressing the nation, he said he wanted a fleet of 350
ambulances.
Cars that are at the district, at the health centers, that they are ready to react to any emergency that comes through. Do we have these on ground? Are they already there?
They haven't yet reached in those numbers.
Then the other thing.
But can I just chime in on ambulances? Because you're even talking about cars. I am talking about Sigulu, Rabachi, Sai, where there are no water ambulances.
I want to share with you the good news, Alana.
But you're going to
last week,
MV.
that MV has been, but
I think
allow her to submit.
Yes, because you remember when we went to Rabachi with you people, we went there and witnessed a very terrible situation in terms of access to social services. Because we also advocated, and we even had these people come to the Equal Opportunities Commission to tell us what is happening. Because after looking at their plans, we had seen that they had budgeted, because these are things sometimes that they could budget, but then they are not given priority. They put them under unfunded priorities. But I think together we managed to advocate, and now they have the biggest MV, which is going to go there, MV Sigulu, which was, I think they started even advertising it before it had started working, way back 2019. But this time around, It was launched and it's going to start working. But
We
then
hope
the
it works.
modalities of that transportation is also something that we need to examine.
But let's
Sai. Because
Yes, I
we've
know,
also
but
brought to
I-
Sai Islands to you.
I know to Sai
So there's a
Island,
real
and
gap.
the Commission is really interested in Sai Island.
Yeah.
This is one of the little islands
Yeah.
on Lake Victoria that has practically nothing
Zero.
when it comes to government
Health.
services and
And you
schools
say we are moving,
and
steady
hospitals. And yes, I understand. Okay, but I think something is in the pipeline being done, because the Commission has spoken, Equal Opportunities Commission has spoken, the RDC has come out, ISER has screamed. I am sure something is going to be done, and we're on it.
Okay.
Now, when it comes to economic, social, and cultural rights, we also have to put in the progressiveness, progressive realization of rights. I think we cannot forget that. Now, I know that Alana is very passionate about this. She wants things done like yesterday.
Alana is a millennial.
Yes,
so
yes,
she's-
yes.
They want things
We
really high.
understand.
Yeah.
But for at the commission, like the Human Rights Commission, that has been monitoring the progressiveness, okay, of facilities. If I tell you what the situation was in 2014 and what it is now, I think efforts have been done. When you look at National Drug Authority and the national medical stores and what they have been done, the other year we're commending them. Yes, the malaria medicines and all these medicines being burnt and rotting in the stores, I think, or expiring in the stores, they're improving, and we are commending them. But we are not saying that everything is perfect. We are saying a lot still needs to be done, but we have to also accept and give
The
credit where it
efforts.
is due,
Oh, yeah.
and also commend the efforts where they are due. Alana,
Okay.
Yeah, because I'm still giving you information here that again, when it comes to the supply of some
Ruth, you're
basic,
protected, don't worry.
some of the basic
Yeah, I'm
needs
checking.
where the vulnerable benefit most, because you know most of the vulnerable people really rely on government services.
Absolutely.
If you wanted to come in from the private angle, then you have cut them out. But we are happy that again they have increased, especially on the lower health units. They have had a bigger budget this time around,
Yeah.
as compared to the previous years, because this time around they have, I think, put there something like 10 billion,
Yeah.
which has not been there before. So I'm optimistic that something is going to happen, and alongside the COVID-19 preparedness, we shouldn't again go back to the same budgets, because anything can happen, you know, to say that we are cutting them, because these illnesses are still there. It's not only COVID which is in place.
Yeah.
Much as we have also witnessed that because of the hygiene practices, by the way,
Yeah.
some of these illnesses have also lowered. They have also gone down. We have fewer malaria cases. We have fewer dysentery or even typhoid cases. But there are those people who have been having these underlying health problems. They were also somehow ignored at the inception. But I think the health sector is also trying to come up. We have to go back and see whether really these people are being helped out. Because you could find a situation still connected to the ambulances, Alana. You know, there are people with high blood pressure, heart diseases, people with, you know, those kind of sicknesses.
Oh, yeah.
Yeah.
But then you'd find that whenever they wanted, even pregnant mothers, they would want assistance, but because of the restrictions,
Yeah.
things were not very good for them
Okay.
during the inception of the pandemic. But I think now things have been eased, but there are those ones still who are at home.
Yeah.
They are still stuck at home because of the issues of, you know,
Public
their
transport is
income,
very expensive,
income
yeah.
and public transport. So they still need that kind of assistance. And again, I want to say that this should not like make us very comfortable where we are. We just need to persistently be in there and ensure that this health system improves, because a lot has come up, and I think it has been an eye-opener to many of the governments in this continent.
Thank you so much. That is Zamina Malole. We're still having a conversation revealing a robust and resilient public health system or for our nation. Alana, as we're winding up, let's look at something to do with another strain. If, hypothetically, if Uganda is hit by another strain, we pray to God it doesn't happen. How ready is our government ready to invest more in that? Or do you believe that now our health sector has been well equipped with skills and basics and trainings to hold up another strain in case it comes, even the populace?
Yeah, I think that you're optimistic that I have a positive view. I don't, unfortunately. I do think that if this is a pivotal moment, and this is a moment where we get to say, okay, let's focus. Because we've seen, the positive we've seen here is, we've seen that if the public health system, you put money, attention, resources, you see, you know, the Dr. Diana is now going over to, I saw them at Kawempe recently, and you know, when you see that, coming in, doing the inspection they're supposed to be doing, putting in the money, the president saying, let's invest in health, we've seen it can deliver, because we did see so many patients when the COVID being really managed successfully, when there was that attention, right? Yep. And so I think it's important that this is, like Zamina said, taken as a lesson. We really focus. We shouldn't have to wait again to have a discussion. You heard us shouting about Sai, Sigulu Islands, you know, there's Amudat which didn't have water. Some of you haven't gone there in the facilities and all of that. And so we shouldn't have to wait for this situation where we ignore our public health facilities to get to this point. And money has come up, and Ruth talks about progressive realization. But from socio-economic rights, also from a rights-based perspective, despite that, you're supposed to dedicate maximum available resources. So you have to scrutinize and say, where can I get to make sure the maximum is put, right? And we need to think about that very carefully. I'm imploring government to really get serious about financing the health sector. We cannot continue to see these disparities in financing, and making sure that financing will go down the most vulnerable. You know, you can finance and most of the money goes in administrative costs. Right? And same thing for donors as well. Work with government and actually finance the health sector for the most vulnerable. Don't put it in administrative costs. Don't bring third-party providers where they're going to implement this project and they take a chunk of the money. Let the money actually go down, trickle down to those on the ground. Put the, you know where the gaps are. Our policy, our every year, the Ministry of Health has its annual sector performance report, and even government does its review as a whole, the gap. They know where the gaps are. So I don't have to even tell them. The fact that it should not be a surprise to them that they, not like Sai, in their records, Sai, you look, there is almost nothing. You know, when you go to Sigulu, nothing.
Alana, you're alluding like totally there is nothing being done.
No, I need you to go to Sai, for example, Sai Islands, right?
I have been there.
We actually filed a complaint there.
Yes.
There is nothing. You know, at some point it breaks your heart when you hear people saying, I just prayed. People tell you the things they do. I got aloe vera, I mixed a concoction, they vomited. When they stop vomiting, they are better, and then I prayed through the night. We deserve better. We truly deserve better. So I hope they focus on financing a resilient public health
Alana.
system.
Winding up, Ms. Ruth Asechindi, we've had instances where pregnant women have lost babies largely due to lack of an effective ambulance system, and patients being detained at health facilities because of the inability to pay. There was one where Alana was drumming a lot online, the one in Nsambia Hospital. I'm sure you saw that. What redress mechanisms are available for victims of violations such as these, from where you stand?
Okay, we are talking about women who, you know, some of them gave birth because there was no ambulance services. But before I even get that, when we're talking about a resilient health service system, it has to be holistic. We have to talk about the transportation, adequate transportation, the availability of the infrastructure, the accessibility of the medicine. Is the medicine, yes, we could have fancy hospitals and health centers. Is the medication there? Is it affordable in the event that the persons have to buy it? Is it affordable? And one of the challenges in Uganda, if you ever fall sick, be very afraid. Be very, very afraid.
When you're in Uganda?
Because accessing the right healthcare system in Uganda has still remained a challenge. Now, the Commission has invested a lot in monitoring the health system in Uganda. We have made so many recommendations, but the progress, even though I talked about progressive realization, has been very slow. Now, as a country, we need to up our act and invest heavily in our health, in our infrastructure, in the equipment in hospitals, whether it is scans. You know, people travel from one health center and travel long distances just to get a scan. And now we are going to start looking at issues of ventilators that we never used to discuss about. Okay, in certain medication that are not readily available in our health centers. For example, cancer patients. We've written a lot about cancer patients. How accessible is chemotherapy in the communities out there, in the referral hospitals out there, not Mulago? Okay, how expensive is it? Can an ordinary person afford it? Now, when it comes to ambulances, I am glad that for the first time, government is going to invest heavily in the ambulance systems. Who is going to drive them? Are they equipped? Are they well trained? Okay, those are the questions that we are asking. Now, we are looking at pregnant mothers who gave birth because they don't have ambulances. And because of the lack, politicians have jumped onto it. And you have seen every MP that is campaigning is buying an ambulance. And do you know what those ambulances are doing? During the campaign period, they are making noise throughout the community. You know, the sirens are on around the communities. After the campaigns, they disappear. Yeah. And the people are told, you buy fuel, and then we take you to hospital. When they get there, they say, how much is fuel? 50,000. Hey, and then you have to also bring 20,000 for the driver. And then they say, but I can put this person on the border and I get them to hospital at 5,000. Very much. So actually the ambulances are not hopeless. Okay, so then are they useful? So then the people, our politicians have realized a need and a gap, and they exploited them. And as the primary duty bearer, the state, I'm calling upon Ministry of Health to look at the issue of the health services holistically, not only pregnant women. And that's the questions you've asked. But I am going around it because it shouldn't be only about pregnant women. It could be you.
It's the entire system.
Okay, it's the entire system, and we have to address it holistically. Not only about child mortality, it is very important. Maternal mortality, it is very important. Or HIV/AIDS. Let us look at it holistically, because every life matters. Whether it is for pregnant women, I know the vulnerable persons need priority. But if we have a holistic health system, then that works for everyone, then we can even work better for persons, vulnerable persons, so that we have a more resilient health system in our country.
Well, that is the conversation we've been having today. We had a couple of conversations online. Alana still believes that a lot more needs to be done, but she loves ambulances never than before. But on the other side, what is on the other side, where the ambulances taking these patients? Are there a team that are ready to receive these people? So thank you so much, ladies. It's an honor to have Madame Zamina Malole, a member of the Equal Opportunities Commission, Alana Kembabazi, Rights to Health Program Manager. You'll again and again you'll see her there, and Ruth Sachindi, the Director Monitoring and Inspection of the Uganda Human Rights Commission. It's because of time that we cannot be in position to have this conversation, but you and I can be more part of it online. We keep it going again and again, and thanks so much to all those that have been a part of this conversation. But key things, the takeaways: one, it's inclusion. We have to be a part of this, you and I as Ugandans. COVID-19 is real, and the other bit, the Ugandan government needs to invest more in the healthcare. Amandru Chamagiro, good afternoon.